Yeah, thank you. Thank you all very much for filling this room. Yeah, it's a pleasure to be here to listen to all of your exciting talks and exciting theses. So I really enjoyed the morning, and I do see there's a lot of spirit and enthusiasm here to drive the field. And I'm happy that I can show you, like from my perspective, how I evolved in science and clinics, what you can do with this approach, what you can change. And I'm very, very happy that I saw already today that this is also the spirit that's more or less here in the program, in all of you, and also within all of your research questions. So I will focus on my main topic of research, pediatric neuro-oncology, but I also will show you in the next roughly half an hour that this was for me not a very straightforward way to get there, and is maybe also not the last station, let's say. So to begin with, I wanted to tell you a little bit about my CV. So this is not Vienna. So as you may recognize, so this is Freiburg im Breisgau, is in Germany, in southern Germany. And actually that's where I started my undergraduate training. So I started as a biologist, not as a clinician or medical student. And I started in biology at Mr. G here at this Albert Ludwigs University because I wanted to do something in agriculture, and they were very good in plant biology there. So I moved to this very nice building here so that you can see here. So very nice 60s building. So nothing with the nice, comparable with the nice buildings you have here in Hungary. But there I learned basics on solids foundation, molecular biology, chemistry, physics, all of which I was always very interested in. And I even taught inorganic chemistry there, so something very, very far from medicine, because I enjoyed it. I think it was always very interesting, but evolving there, I mean, is now like more than 2 decades ago. New arrays were evolving. It was incredible. There were technologies emerging where you could test, several thousand genes at once, and you would not have to do one PCR per gene. So this was the area of evolving molecular analysis. And this had a huge impact on molecular medicine. And this is why I then thought, I think this is the main interest. This is something that I want to do. And therefore, it was only reasonable to also add on and switch to medicine. But I then moved to Vienna. So now you may recognize. So this is Vienna. And but there continued to do molecular biology and continued there with a Bachelor of Science. In this process, so because I maintained doing this, I got an in-depth knowledge on cell metabolism, biochemistry, cell biology, and molecular biological techniques. So all of which things that are now have arrived in everyday medical practice. So everyone is now confronted, let's say, but in a positive way, with different genes across all of pediatric or other medical topics. And back then, this was not the case. And therefore, I think this was a very, very good foundation. And back then, I also then already chose a topic for the bachelor thesis, which was in the field of cancer research, but was still, some inorganic gallium complexes and trying to check how they work on lung cancer cells. So something very far from pediatric cancer, but this was my first connection to cancer on the Cancer Research Institute, but still connected very much to basic research. In parallel, I did my human medicine studies. You maybe recognize a repetitive pattern with respect to the shape of buildings where I was training. But it looks much nicer when you're inside and you look out. Yeah, that's where I trained medicine. I went abroad a little bit. I went to Valencia, to Erasmus. I wasn't really aware back then that this would maybe have something to do with my later career, but this was the first time that I got in touch with neuro-oncology, actually, and only because this was very confusing to get the courses there. They told me I could not enlist into the courses. Then when I got there, they said I was too late, etc. So that's why I ended up with neurosurgery. But had first contact with pediatric neuro-oncology, and I actually kind of liked it. So I did practica in care for the elderly because I didn't know where I was going to in medicine. After I did care for the elderly, I knew that I would rather go for pediatrics, which is a individual choice, let's say, but for me it was the right thing. I did different jobs on university in histology, in biochemistry, so different things, which all taught me some little bits, let's say, about what to do and what I could do. And continuously I worked as a scientific co-worker in the lab. Practical experience, we had to do some of these things, but some of the things were also out of interest, like emergency clinics in Mexico, etc. So, but I then more and more learned that maybe pediatrics was the right choice. So why pediatric neuro-oncology? So having learned this, having seen a lot of things, it more and more emerged what I kind of wanted to do in my professional life. One thing was oncology. This was kind of straightforward based on molecular medicine study sets and so on, because it's a disease that is very much cell oncological driven. So it's a lot of cell biology, which I always liked. It's the emperor of all maladies, so it's also a significant challenge. It's highly interdisciplinary, it's research driven, and it's an innovative field. So this is why I picked this. Why pediatrics? Because of its complexity. You notice sometimes that I had to change the whole talk yesterday from German to English. I'm sorry for that. It's complex. We have seen this today already in many of your talks. So you have to consider many, many different topics that evolve across age groups. For example, there's a large disease variety, there's the developmental context, so you always have to consider everything that you're doing, treatment, disease, in the context of a still developing, growing body and brain. It requires a lot of communication skills for those of you that are in the clinics. That is maybe obvious. And there's also a significant proportion of spontaneous reactions, which I always also liked. And then there's logical synthesis, is neuro-oncology. Why? Because the brain is a fascinating organ. It's driven by connectivity, so it's not driven by pure tissue mass, let's say. So it's more brain mass is not significantly more brain output, let's say, but it's connectivity. There's plasticity, particularly in children. So these children can rewire, they can regenerate. So this is interesting. But on the other hand, also treatments that we're doing may influence this plasticity. There's a lot of developmental biology in it, which I think always was interesting. There's a high clinical need, and we have various therapeutic concepts. So it's not that boring from a clinical perspective. So that's actually, from this point of view, it was kind of logical to pursue this. And in addition, it requires a lot of networking and teamwork. And I think this was particularly something that I always like to do, and I always encourage people to do. So what about the network? And here also just to show you how this evolves. Now we have a really big network, but it all starts at the nucleus. So I was at the Institute of Cancer Research doing my lung cancer stuff, but then got to know other people that were maybe more in the brain cancer field. And then I got to know my then later supervisor and head that was doing pediatric neuro-oncology, which drove me a little bit into that field. Via her, I got to know all the other doctors that did other scientific and clinical projects, got to know the other surgeons, etc., pathology, then connecting to other sites like Heidelberg, for example, continuously evolving the network and adding new projects to Boston, Brno, Berlin, and everything adding additional aspects and projects until moving to patient organizations that give more input and other input. And I think all those projects are very interesting. And now finally, and this is not even the whole network that has emerged, just by curiosity and starting new projects and working together in a team. So just with this, I wanted to highlight that it's all a process, and that I encourage all of you to kind of engage with people, exchange ideas, and really think of how you can then drive things forward and what you can do in a team. So from the clinical track, just shortly summarizing, I did my specialization in pediatrics, so that's how it works, like for roughly 6 years. Had on-call on the ICU, etc. So seeing different parts of pediatric oncology as well, but also did 5 months of paternity leave. Then I did my specialization in hemato-oncology and worked as a consultant, again going on paternity leave, but also leaving to Heidelberg for half a year to do distinct project on rare cancers. Overall, I have seen more than 800 new patients in the clinical track. We have a tumor board where even more than 800 cases have been presented across all of Austria and internationally. And I initiated back in 2020 a precision oncology board, which was kind of one of my favorite projects because it synthesizes molecular biology and clinics. It's for innovative treatments, and there we have this regularly, and we also have patients from abroad presented and discussed in the tumor board, which then really shows you the benefits also in the clinics. Scientifically, I've shown you I've worked in the Institute for Cancer Research first with something completely different, with metallocomplexes, with gallium, etc. But this taught me a little bit about translational research. I did my PhD study in a program that's called Clinical Neurosciences on epipneumoma, which a tumor type that I'm still interested in. And ever since, we fostered a network. So we started more than 10 years ago to establish a network for translational research on pediatric brain tumors that is meanwhile very successful in Vienna. And I did several postdocs, for example, in Heidelberg or in Boston to do research on certain aspects of the whole research projects that we had done. So now in the second part of the talk, I would like to kind of highlight what we have done and why. So I think for some of you, I don't have to repeat that treating kids with cancer is a success, but we still have limitations. So approximately 300,000 children and adolescents worldwide develop cancer each year, and we can cure, and we have seen this today already, approximately 80% with surgery, cytotoxic chemotherapy, radiotherapy, but also additional agents like corticosteroids, but also targeted agents. Meanwhile, but a significant proportion, about 2/3, suffer from significant late effects that some of you are also studying. How is this for CNS tumors? So CNS tumors are the most frequent tumor type and leading cause of death, as well as morbidity in children with cancer. We have more than 100 different CNS tumor entities, so it's highly complex. And some of the highly aggressive tumor types, they account for the majority of these deaths, like medulloblastoma, high-grade gliomas, epipneumomas, and some other rare entities that are even more difficult to study. However, on the other hand, we only have 5 approved anti-cancer compounds, so novel agents, as compared to adult oncology, where you have many, many more. And there are drastic differences in the sensitivity towards these classical treatment approaches. So summing up, we have to do better, and I think we can only do this together when we work on it together. Here just a summary why this is so complex. So these tumor types differ widely in between age, in between the region of the brain, for example. So it's very important to take this all into consideration when you plan treatment or when you also try to improve treatment for patients with brain tumors. So one thing that we started with was, as I said, epipneumoma. So we were interested in certain molecular features of epipneumoma, and one of them was telomerase, so immortalization. And what we found back then was in a very small cohort, a single center cohort, but as it was very, very well annotated, we could also make some significant impact with this and study it, that tumors that were negative for this telomerase expression, they had a much better outcome as compared to tumors that exhibited this feature. And this led us to the concept that maybe stem cell factors are very, very important in the tumorigenesis, but also in maintaining a malignant phenotype in these tumors. This is a very common concept in pediatric oncology, as we think that as compared to adult cancer cells that acquire mutations over time, childhood cancer cells, and you can see this here, are rather kind of cells that take a side way during development are stuck in a certain developmental stage, but maybe this is something that we can also use for treatment. This is called maturation therapy. So maybe we can push those cells back onto this track and then treat it better. And as we had done those studies on epipneumoma, we also kind of interrogated this in epipneumoma. And back then, there was again a new technology. So now we could not only interrogate thousands of genes on one slide in a tumor, but we could do this for every single tumor cell. So we applied back then single cell RNA sequencing on epipneumomas. And what we found that there was some kind of hierarchy. So the arrows point into a direction of a developmental trajectory. So you can acknowledge that these are kind of the stem cells, and these are different branches that tumor cells can evolve into. So these are all cancer cells. So the cancer somehow has a stem cell department that mimics normal kind of development. So you can look at it as like a tree. So you have a root, and then you have branches that it develops into. And importantly, I mean, how would you try to get rid of a tree? You would not always cut the branches, but you would try to get it out by the root. So this was kind of the concept that we also thought that would be interesting. And interestingly, we found that this was also true when you look at the clinics. So we found that this ependymal-like signature, which you see in blue, which kind of reflects the branches, was also associated with a better outcome. So if you have a lot of stem-like features in the tumor has an inferior outcome. And we found one feature of those tumors, and these were FGF receptor expression. So one receptor that was expressed highly in the stem cell compartment, but absent in this more mature compartment that was characterized by ependymal cells, like in green, that it would express FOXJ1. So we took this into our next study and thought whether we could target fibroblast growth factor receptors in epipneumoma in order to improve treatment. And indeed, what we could see, these are now tumor-derived tumor spheres, so all epipneumoma cells. Back then, there were almost no models available, but meanwhile, we have, within our program, we've been able to establish several epipneumoma cells. So just today, there's a recurrent operation of an epipneumoma patient, for example, when we immediately take it into culture. And what you can see here, so when we treat these cells with the inhibitor, particularly with this one, we see upregulation of FOXJ1, which kind of shows us that this is differentiation inducing agent. And we also put this into the clinic in a refractory case. This was a case that was progressing on this blue therapy, but then we added this agent that inhibits FGF receptors on top, which then showed further stable disease for 1 year, which was in the context of a fifth recurrence, a certain success, as you can appreciate. So we do think that these are, for example, concepts that you can take into the clinics and then also pack into individualized therapeutic concepts. Another factor that we investigated, for example, and this came just out a couple of weeks ago, was PDGFRA in high-grade glioma, so one of the most fatal tumor types. So here we investigated whether a new agent, avapritinib, would be more effective in targeting PDGFRA-altered high-grade gliomas. And what we found, and these are xenografts, so mouse models. What we found is that avapritinib was very, very effective in reducing activation of those receptors. And lucky enough, we could make these drugs also available to patients. And what you can see here is that in this patient, for example, that was progressing with this huge cystic lesion, he had a very, very good response to this agent, similar as this patient and this patient as well. So especially on the contrast media. So we really could rapidly take concepts from the bench to the patients within individualized concepts. And when looking at the MRIs, these were patients that were in the third line and metastatic of their treatment. We even saw complete remissions, which showed us that this is a feasible concept, and this was then taken on into clinical studies. So what I want to show you with this, and maybe also with the next one, that based on all your clinical duties that you do in clinical observations, there are always windows of opportunity that you can take into the clinics and think from the lab to the patient and back, and to integrate those concepts for science, but also to the benefit of patients. This is another paper where we used a targeted compound, which was entrectinib. So back then, a really novel ROS1 NTRK inhibitor. And as you can see here, this is a case of a patient that had received chemotherapy, a very young patient, gross total resection, but then had CSF dissemination. You have to acknowledge this happened within 6 weeks. So when the patient was referred to our center, so really huge metastatic lesions. We started treating this patient with entrectinib 6 years ago, and I just saw him this week. Yeah, he's still on treatment. And why do I say this? Because one main side effect that's only there in children is bone fractures of this treatment. And he just, a couple of weeks ago, he even had a fracture of his hip. So very severe fractures in children. So we have to think about how to reduce and how to manage this patient with these side effects. So it's always important to take this into consideration as well. But we managed to stop this really, really wildly growing tumor. And meanwhile, this is even approved. Talking about approved agents, this is maybe the most prominent one is BRAF-V600E that was developed in melanoma to be inhibited. And already a long time ago, we tested this in a couple of cell lines, and you can see here that this efficiently worked. We also again took this already years ago into the clinics, treated this patient with a targeted inhibitor, and again for about 1 year saw a response in this heavily pre-treated patient. So all kind of taking concepts from the bench to the bedside that were then taken into clinical trials, and some of them are meanwhile even approved. Other concepts, of course, apart from targeting certain receptors, target other parameters of cancer cells. This is a concept targeting DNA damage, for example. So rethinking chemotherapy for gliomas in this case. So this is a certain glioma type that's always characterized by histone mutation and ATRX loss. And what Anna Lemmerer, she was a biologist in the lab, what she found out was that they always go together and they induce a sensitivity towards DNA damage stress. And we combined PARP inhibitors that have been developed for breast cancer, so for BRCA altered breast cancer, with topoisomerase inhibitors, when could even show that this would impact stemness features, but also led to response in a patient that was refractory and progressing after irradiation very early on. And again, roughly about a little bit more than 1 year, we could stabilize this tumor. Until then, unfortunately, it progressed. So, you know, it's not the end of the story. How do we do this in a translational setting? So we work closely together, again, teamwork with neurosurgery, with the labs, to really get tumors from the OR into culture so that we have novel models to treat with. And we have developed roughly more than 400 pediatric brain tumor models that we can use across all different cancer types. And they are now used in platforms and across the globe to develop better therapies. Other opportunities, so I've talked a lot about novel therapies, but other parameters that may influence the clinics and that one can think about are biomarkers. One of the biomarkers we developed was a microRNA-based biomarker. So we did this in ETMR. This is a certain tumor type that is very rare, but characterized by amplification of a certain microRNA cluster. So which is why we thought, why not investigate this in tissue? And what we found is that indeed certain microRNAs, you can see it here, or you can see it here, were highly overexpressed in tumor tissue of these ETMR patients. And we then set out to investigate this in the blood. And indeed, we could find high levels of this microRNA in blood that was correlating to MRI. And when tumors were resected, for example, these levels were going down. So this we think this could really be an additional biomarker to monitor patients. These are very young patients. They need sedation for every MRI. So a more precise or more frequent biomarker may help. And you can also see that in this case, where the tumor was progressing, unfortunately, the biomarker went also up. So you can also use the biological knowledge to develop new biomarkers and take this into the clinics from this perspective. So not only therapeutically, but also from a management perspective. Another issue is always the application. So I advise you or encourage you to always think about how can this clinically be applied. This is very complex. And in this case, we were so lucky that it's very simple because I have talked a lot about single cell, 5,000 genes, blah, 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 blah. This is a simple PCR. Yeah, you can do it within 4 hours in any lab, and it's specific as well. So we think this is, if it comes to a biomarker, also an advantage that one can think about and think back after very, very complex analysis. How could this be applied in a simple way, maybe? Now more complex, I think, again, but maybe to be implemented in a simple way. So many of you may know that we have been introducing DNA methylation analysis in diagnosing CNS tumors in the past 10 years. So this is just a map of one of the hallmark studies showing you that more than 100, or here it was 91, tumor types can be classified based on DNA methylation, so the methylome of the tumor tissue. And you can classify the tumors like this. And we thought, why not try this in CSF of patients? Because those tumors maybe shed the DNA. I wanted to show you that these are not only kind of molecular and pathological things that may have an impact, but we then thought maybe this has a clinical impact. And this was just a small study we did where we said, in those different molecular subgroups, maybe clinical differences. And indeed, we found that one group of medulloblastoma is characterized by spontaneous hemorrhage in the tumor, which of course has a clinical impact. So very, very important. So it's sometimes also important to consider such clinical features that are different. But now to the analysis. So what we have established now and trying to summarize now in a paper is we have established a workflow that maybe allows us to identify the tumor type even before surgery, or if there's doubt whether this is a tumor. So we would acquire CSF, either via the reservoir, lumbar puncture, or if extraventricular drain is in place, process the CSF and then perform DNA methylation analysis. And what we can do, you can see it here on the map with the star. In a certain proportion, it really correctly identifies the tumor type just from CSF, so without taking tumor tissue. And we even can recapitulate the CNV profile, so the copy number variations of the tumor, which is really nice. And I think this will be the future in some of the tumor types where we need this preoperatively as an information. So to sum up, I think I could show you that novel patient-derived models enable us to develop improved therapeutic strategies, and that sometimes you can even straightforward take this into the clinics in very, very complex cases. But this requires precision oncology approaches that integrate all specialists, so surgeons, radiotherapists, oncologists, but then they enable precise treatment for high-risk tumors. Combination with organoid technologies, for example, as I've shown you with those tumoroids, yield more relevant models that reflect the whole complexity, not the whole, but better reflected, and that now, even for CNS tumors, we develop liquid biopsies that enable more monitoring possibilities, but also better diagnosis, as we have it for other cancers like liquid cancers since decades. So I really have to emphasize that all of this is always a group effort. And I have to thank many, many people that helped me along the way and are still enthusiastically working, and particularly a lot of very, very young and talented people. So you can see here our lab. So it's all teamwork. I have to stress this, and it's all translational teamwork. So you see here our lab group, but also the clinical trial group here. So that they're very, very essential, because it does not work if you do not have the ethics and the whole protocols running. The lab doesn't work, and vice versa. It does not work if the clinics is not running, if you do not have dedicated and talented nurses that take care of your patients. And even we try to integrate, and we're integrating the whole psychosocial dimension. So this is our psychosocial team together with the teachers. And I think it's very important across whole of medicine, but particularly in pediatrics, that you think about all of these aspects, because they really drive expertise in your centers, but they also drive innovation and research. So, thank you.
Thank you. That was wonderful. So my question is, could you talk about the pros and cons of organoids, since you've worked with them?
So I mean, one obvious pro is the scalability. So it's compared to mice, and you can produce much more organoids. And the other pro that I think is even more relevant is the human disease. So for example, the microRNA cluster that I've shown that we use as a biomarker, it only exists in primates. So it wouldn't be there as a microenvironment factor in a murine system, so in mice. So I think that you have a human background is a real advantage. The disadvantage, the obvious one for preclinical testing, is the whole pharmacokinetics. Yeah, that you would have in a mouse, of course, with different drug levels going up and down because it is metabolized. But again, here you can argue that you have the murine PK in the back, yeah, which is not always reflecting human pharmacokinetics. So I think those are the main factors. So I think it's very important about every model to think about the pros and cons. What is the research question, and how can I integrate them? And at best, I can spare some mice and acquire additional information.
Thank you.
Thank you for
Thank you
this
so much.
question.
You just highlight the importance of pediatric precision oncology in pediatric CNS tumors. And even you mentioned that you have a weekly or every second week at an international tumor board. And just looking for what is your daily routine to identify target genes in CNS patients. For instance, in Hungary, we are doing like TSO 500, which is like less than whole exome sequence, but pretty close to that. What is
we have also TSO 500 as a standard for all the brain tumor patients.
Do you see any benefits for whole genome sequence for patients, or doesn't mean?
I think if it's scalable and if you have the same sensitivity, I would rather move to whole genome sequencing, but it's not there yet from the pathologist side to have the same accuracy. I think the particular advantage of whole genome sequencing would be that you would, on the same line, because you need the germline as well, also be able to identify any predisposition syndromes that are maybe not part of the TSO 500, because although the companies have tried to also adjust it to pediatric type of cancers, we all know that those panels are vastly designed for adult entities, and so we maybe sometimes miss some pediatrically typical things. Yeah.
Back to your tumor board, precision oncology tumor board, we are hoping this very soon we are able to refer some patients to your tumor.
Yeah, that's we're happy to do so, and I think that we even had some patients from Hungary referred at some points for BRAF. Yeah.